Good morning. I'll just take a few words to introduce the speaker today, um, Dr. Santhosh, Mathew, sir, and Dr. Saira, madam. It's my privilege to introduce them. I've known them for over 23 years now, and they were my bosses when I was working in EHA. Sir did his MBBS from Kottayam Medical College and his post-graduation in internal medicine from CMC Ludhiana. And madam is a graduate from Trivandrum Medical College, and she did her anesthesia from CMC Ludhiana. So, sir was the CEO at Emmanuel Hospital Association, and he's currently working as coordinator of training for ICDMA, International Christian Medical Dental Association. He's also on the board of CMAI, and sir is a very uh, astute clinician. I remember when I was starting my internal medicine journey also there, sir used to come and give advice. He taught me how to do upper GI endoscopy, and he was very patient with me because I just landed with the scope and I was just trying to get to the second part of the duodenum. And he taught me that. And so he's a very humble person, and he's worked in many of the EHA units before he became the head. Rexall, Kachua, and Lucknow. Some of the students have gone to these units, Auden Chitram. And I don't think there's any better person to talk on this issue, money matters in medicine, ethical and practical dilemmas. So I'll hand the stage over to sir.
Thank you. It's an honor and a privilege, and our teaching where we were told that cost should be always considered. And years of working in rural North India, it was All of you know most of it. And she went to the nearest, not nearest, the topmost private corporate hospital in Delhi. What was done? I can tell you, in rapid antigen test and RT-PCR, CBC, chest X-ray, IgE levels, virological panel, and you got these investigations. And this is gone after 48 hours. And then she called, Dr. Santhosh, what should I do? I said, what should I do now? Before you go, if you had just given me a call, and I asked, what did they do? Oh, they gave me paracetamol and sent back. I said, if you had called me 2 days before, I would have said the same thing without all this cost. Now, how are you? Oh, fever went up that night itself. Now, you might say it's extreme, but extreme has become the norm. This is the norm in most private hospitals. And the whole question is, how much she spent. Look at the cost she would have done. Anyway, she didn't go for the second opinion, and she was told to come back after 48 hours and 7 days later for a final review. Consider just the costs she would have incurred. She could pay because she was well off. She is the director of an organization with enough resources. That's a different matter. But if it was a daily wages worker, a Bihari who is in Kerala, or a Bengali who is in Kerala coming to Believers, I'm sure Believers won't do it. But I'm just using this as an example. So consider the indirect costs always. Something which we should never forget. One of the studies from Vietnam shows that almost 30% of the costs incurred to a patient is the indirect cost. Indirect cost involves the direct non-medical cost and the indirect medical cost, not the non-medical cost. Now, studies show that it is anywhere between 30 to 120%, which means if they are paying 1,000 rupees to the hospital, they might be paying 1,200 for just to reach the hospital, or in relation to the hospitalization or hospital coming in. We don't even think about it. We don't even are not aware about it. So average it says about 80%, which means your bill is 1,000. They would have spent another 800. Now, I think so. What is happening is almost 60% in rural and 70% urban are not going to the hospitals. I had a great experience of 5 years in Delhi, which I hated. We didn't want. We are always in rural areas, and 20 to 25 Sarah was heading EHA, and I was in Delhi. So a very interesting learning experience. I would say that I should have done it early in my career. That 5 years was a learning, because I was in a small mission clinic. All the patients who come would be from the big names, the Apollos, the Maxes, and this thing, just to get a second opinion. So it's a learning experience of 4 years of how the market works. And most of them say, we will not go unless we are on our deathbed. So very important to understand that the whole question of direct and indirect costs. The other is the art of making a diagnosis. For physicians, it's simple. This is a patient who came after about visits to the 4 topmost hospitals in Delhi. Now, for a normal physician, I don't know how many physicians are here. This is very simple. Hypertension with anemia, there is only one diagnosis for us: chronic renal failure. That's how we are taught. Now, he has been to at least 6 physicians, echocardiogram, everything possible was done, but somewhere in that journey, nobody asked what the diagnosis is. Occam's razor or the Paris money. The commonest diagnosis, or what is evident, is the diagnosis. It's very evident, but I realize this is even our junior doctors who come to us, or the residents who come to us, people who are trained in our premium institutions itself, do not make a diagnosis. They'll put a list of possibilities, hypertension, anemia, but hypertension, anemia has to be correlated. Why? The creatinine was, everything else was done but for the creatinine, and this lady's creatinine was 14. She had a girl, 7 years, 4 years and 2 years, 3 children. She sat and cried for 15 minutes and said, what will I do? I don't have the money for renal transplant. Now, 6 years was wasted by somebody not asking the question. But at the same time, we investigate relevantly. This is again a friend. For 10 years, he was losing weight. He used to go to Chennai every year, get his full investigations. The symptoms and this thing was very clear. I'm not going to ask the diagnosis here. Maybe the physicians can look at it and think about it. One very important diagnosis missed, which is very evident from the history. And finally, he was in shock and couldn't be brought. I saw him, and it was clinically very evident what it was. It was stage 4 HIV. But, you will go to the hospital, doctor will not examine, give a list of investigations, the executive checkup, no? Because everybody does executive checkup today. So the executive checkup is normal, go back. But then, how do you miss if you don't think? So the whole question is, very interesting to this statement I read recently. A physician with a low level of confidence in this or a level of diagnostic accuracy will overtest, whereas an overconfident physician will under-evaluate patient's concern. Very interesting statement. Neither be overconfident, nor be low confident. How do you train our students to be adequately confident, not missing? So some reasons we need to constantly teach is that, see, what you do depends on your differential diagnosis. Do you ever talk about the pretest possibility? What are the tests required? Because you might say that, okay, now we have a package, let the package go. But is the package reducing your critical thinking ability? Now with AI, there's no need for any of this. You can get everything on AI. So are we producing doctors who cannot even think critically? Because critical thinking is key for internal medicine. Nothing like making a diagnosis and say, oh, I made this diagnosis and we just proved it. We put the other way around. That's an intellectual satisfaction at least some of us get. So the important thing, especially in the context of AI and changing medicine, is very important not to lose the ability to critically think and come to a tools will come, but tools should not change our ability to think, our critical thinking. Because if you allow tools to impact your critical thinking, you're producing automatons. The machines will tell you what to do. You will never know how to think. Let's come back to encouraging our young doctors to think through. It's like another story. Again, an elderly man came to me with vague abdominal pain, primarily for diabetes control. He kept on talking about some vague abdominal pain, and then I examined and found some reduced breath sound. So finally, he had an X-ray, and he had some history of TB in the past. And then finally found this huge mass in the right upper this thing. What would your diagnosis be? Chronic smoker. The first thing was chronic smoker, CLN. Normal thing. So I sent him for investigations, and he panicked. He went to the topmost center in Delhi, got everything done. How much would you have spent? Any thoughts? If it isn't believers, how much they would have spent? Sorry, Thomas was my junior doctor, so junior consultant. I can ask him. Sorry, I'm Thomas. What do you think you would have spent? Pardon? 15,000. Praise God. I hope I will get treated in believers. He spent 78 to 75,000 over 48 hours and came back and said, now I need a CT guided biopsy. What should I do? What should I have asked? I asked him that question, but he said, no, I'm going to pass nahi hai. I asked him, do you have an old X-ray? He said, I don't. I said, because there's no hot spot, don't go for a scan. Review after about 3 months. But go back and, this time I became more confident. I said, go back and look in your records. They have an old X-ray. 2-3 weeks later, he came running and said, "Mera purana X-ray mil gaya, sir." So I got the old X-ray and compared to same. Now, he had a TB earlier. That was, and in that lesion there was 40 calcifications, and there was a sign that was a calcified old lesion. I mean, still can't rule out malignancy. But then that question, and every time he comes back, he'll say, "Sir, mera 70,000 rupees aap nikal diya mera se." And he keeps reminding me, "You made me waste 70,000 rupees." I said, "I didn't waste. You ran off." But then physicians might say, I mean, you can't wait on this. This kind of a lesion is dangerous. So sometimes this is what happens when you put investigations in the front. Incidental omas. You find incidentally a tumor and chase it. Time and time again, there are case studies emerging of how we follow incidental findings and end up messing up a patient's care. So because the problem is the eye does not see what the mind does not know. How do you teach and train to hear, see, to understand what it is and hear stories? And more is missed from not looking than not knowing. So both are there. You need the knowledge and the observation. Okay, you need to look. At the same time, you need to, if you don't know what you're looking for, you'll not, but if you don't look, you won't see. So at the same time, don't overdiagnose. This is a classic story, happened in the topmost neurological center in one of the previous capital city of India. This lady was brought with tremulousness, all those, and then was recorded high at that point of time. But her story was interesting. She was a very spiritual person, counseling and doing lots of this thing online for 14 to 18 hours a day. Very emotionally, hyper character. Sent to a neurological center. They CT MRI showed a lacunar infarct. She was put on 2 antihypertensives, 2 antiplatelets. She finally, because she was not getting better, she walked into OPD. I put her on the bed to examine, and suddenly she threw a fit. And the fit was classical, non-organic. BP was very low, normal. She was on all kinds of medications. Now, we do know that if you do normal patients, MRIs, there will be a good number of, some percentage of people who have infarcts with no clinical correlation. So would we see an MRI and take a diagnosis? All I need to do was stop everything, assure her, put her on a counseling. She refused to do that because she felt that God will heal her. But I'm not negating the importance of God healing. God will heal. But then, she was so confident that this is something more than this, and she went off, and I don't know what happened. So very important for us to consider that everything need not be diagnosed, but don't miss this. This is a very interesting situation which I was challenged by. A 70-year-old man comes, smoker, and he was red, plethoric, and his hemoglobin was 22. Smoker, this thing, any smokers, you can have polycythemia. But then that 22 was very high, absolutely much more than what I would have ever seen in a smoker. So I sent him off, and others had already sent him off looking at, okay, it might be a myeloproliferative disorder, polycythemia vera, go and get all the other investigations. I told him, you go and get all those. He came back after 3 months. He said, do you go and do it? He said, no, I went off to home. I said, where are you from? He said, I am in Kumaon Hills. That is, the height of the Himalayan ranges in Uttarakhand. Suddenly it clicked. I had not asked that question. I thought he was from Delhi. The correlation of smoking and the mountains, hemoglobin will go up. I said, why didn't you tell me? Sir, aapne pucha nahi hai. So I said, I asked you, where are you from? You said, from Delhi. Now, that is, adu wo to main ab mera ladkas ke saath reh raha tha. So what you're saying is, came down for 3 months to stay with my son, but actually I spent most of my 9 year in the Himalayan ranges. Now, I realized this statement, uncommon manifestations of common diseases are more common than common manifestations of uncommon disorders. Don't think out of the box. Sometimes you need to think logically. I'm just sharing this so that these things will become part of our teaching and training. And think about protocols. Consider the protocol very carefully. All around this now, the checklist manifesto, we come up with all this protocol. This is the protocol. I have a dictum. Wait for 10 years before you decide whether the protocol is worth following. Because in 10 years, they will turn around and say, oh, we have changed it. Or at least 5 years. Look at the PSA guideline. Many years back, the PSA guideline, every old man, everybody above 40 years should have a PSA, or 50 years. Very interesting study. At the end of 25 years or 30 years of PSA, so many went diagnosed, but the death rate never went up. Actually, death rate dropped. So what are we doing? We made more prostatic cancer diagnosis, but the death rate did not go up. So much so that latest guidelines say, if you have 1,000, only one of death will be avoided. My dad went through this, and I called up the topmost urologist in, come, we'll do a biopsy. My father was 78. He said, nobody will touch me. If God wants to take me through this, I'll go. He lived till 90 with the same PSA of 11. Nothing happened. But all over the world, we followed this protocol for about 20 years. Now we say it is not required. And this is true in many other situations. Look at, there was a time when we were studying, we were told that mild osteoporosis, everybody should be put on calcium. If you had put, how many win? 5, but the rest 95 would be waste. Or we were told when we were, in cholesterol itself, anything less than high, more than 240, now it is 200, it should be put on treatment. Now, somebody else will turn around and say, at least we saved 5, or at least we protected 8. But the whole question is, how do you manage protocols? So the ability to look at a patient and ask what to ask. I always ask junior doctors, a young man comes with hypertension, what will you do? The first answer, I'm not talking about Patna Medical College or our top institutes, people come. Sir, you're in VMA, van line. I said, the first test you will do is VMA for a young hypertensive. What will you examine? Would you look for a radiofemoral delay or a renal bruise? Simple things. Because that logical thinking and ability to think is no more part of our teaching. So how do you make people to ask the right questions? Examine logically. This all contributes to the final bill, reduced in the final. So never underplay the importance of making a syndromic, locational, etiological or microbiological diagnosis, because teach our students, nurses, doctors to be diagnosticians. Whether they become physicians or surgeons or gynecologists, that's a different matter. Help them to think critically. At the same time, please tell them don't use the shotgun. Okay? Because the shotgun, you will get immediate gratification but delayed desolation. What is shotgun? In North India, shotgun is 1 antibiotic, 1 steroid, 2 antibiotics, 1 steroid, 3 NSAIDs. Okay? You know the azithromycin. All my friends will call him that, sir, uncle, I had cough and cold. I started Azi, not azithromycin, Azi. Not better. What should I do? That is after 2 days of cough. And you know the steroid. Philip has done a lot of studies on steroid. Because immediate relief. Do you really require it? at the same time be evidence-based. Now, not to underplay this, I don't know whether Thomas was part of this thing. In 2004, I remember all the physicians coming together to do a study or make a protocols. And we were making a protocol for meningitis. And I was an old-timer even at that time. I said crystalline pencil is the best. 10 rupees or 10 rupees per vial. What is the problem? Ceftriaxone had just come in. So the junior consultants who came from Vellore and Ludhiana were sitting with me. They said, no sir, you are old-timer, we should do ceftriaxone. I said, prove to me. I was humbled. I had to eat the humble pie. They proved to me. They asked a simple question. How many days will you give CP? I said 7 to 10 days. How many times a day? I said 2 hours, too early. 12 times. You know how bad to the vein CP is? I said, I know. How many times the cannula has to be changed? I said, at least 4 times in the week. How many times a nurse has to go up and down? Sir, calculate the cost. That's the time when I learned that, evidence is not about evidence medically alone. Evidence is also about other factors. And finally, we calculated at that point of time, there was a cost. And we realized that CP was much more costly than ceftriaxone. I said, agree? Now I agree, because it's only twice a day, 2 grams twice a day. And, the additional cost must be much less. And finally, let me conclude with a few thoughts on chronic illness. Never, when a chronically ill patient comes in, think more than what you think for an acute patient. This is a missionary from Nepal who came to me, who came to us in the clinic. He went to CMC Vellore and they put her on a picture man 10 minutes. At that point of time, he was already on warfarin. He had not started. I said, why didn't you start it? He said, it is about 4,000 rupees a month. My whole salary is about 7,000 a month. You are telling me I should spend 60% of my salary on this one tablet? I said, but then you have to come every 6 weeks to get your PTINR. This, you don't need it. But then that was a learning that, it's easy for us to write something without thinking. I would still go for that if they can afford, but today it's much more lesser. But and he's coming all the way from Nepal, a village in Nepal to Raxol, to come for every 6 weeks, he'll pay much more. So I said, I can't help you, but this is all I can say. What about chronic illness costs for diabetes, all things? This is a family members numbers I'm showing. Now, if you buy online, but if you buy generic, you almost save 15,000. Now remember, for a pensioner, this 15,000 is important. We might say this is the best, but is that the best? You might say generic quality is poor. I don't know. This man came, the story is here. He would never take tablets because somebody had put him on levetiracetam. Would you give phenytoin? It's out of our protocols. But then this man, if he has to survive, he gets only. It is not just remember, it is not 1,000 rupees daily wages in Kerala. It's 150 daily wages in Delhi. Okay, so you are getting about 150 rupees a week or 300 rupees a week maximum, and you're putting on a drug which costs 720 per month. Would you expect him to take? My learning, this has been in my 4 years in nephrology. If there are any nephrologists, I'm not against nephrology, I still love nephrology. Look, sitting in CMC Ludhiana dialysis unit for 4 years, every day we would put about 10 patients on dialysis, all coming in stage 4. One night, after about 2 years, one daughter of a patient came and said, "Sir, hum log le ja rahe hain, we are taking the patient home." I said, what happened? Because it was so encouraging for me. Patient come with acidosis, encephalopathy, hyperkalemia, put on dialysis, next day patient, "Sir, hum theek ho gaya." That whole, I was a young consultant and anything. He said, "We have sold our cows, the farmers, sold our land. We are only a house now. If we continue this, we will have to sell our house. Next week, actually this happened. I sat down, looked at the 1,000+ patients we have gone through. I realized 95 of them we had lost for follow-up. And the question came back to me, how many of them would I have pushed into poverty by pushing them for chronic dialysis? And I walked out of nephrology, not because of that alone, I still love nephrology. But then the question is, do we consider reduce hospitalization if at all possible? We talked about endoscopy. This was my endoscope. Just look at the bill. It was a 1-hour procedure, but they are already put it as admission because for them it is one extra statistics. I know believers may not do it. So, in the context of this, try shifting as much as burden to the hospital, to home also, for the elderly. This lady had, for physicians, might be interesting case. She did not, said, I am absolutely fine. The family forced her to get some tests, and they found this 12% monocytes, high ESR, AG reversal. So I said, there's something going on here, 80-year-old lady, has to be a myeloma, get this. She said, I don't want anything, no hospitalization. So this came. I said, it is, next day, so her cousin was my mentor. So he called me and said, Santhosh, you have to do something for her. She won't listen to anybody else, you have to tell her something. So I got on call and she said, I am absolutely fine, don't ask me anything. Then the casual conversation, I said, how is your urination, how is your stool? He said, I'm okay. The son-in-law was in the back. He said, she goes to loo at least 20 times a day. I said, what about stools? Oh, every half an hour she'll go and pass stools. It clicked. Something is happening there. And she found out, finally, forced her to go to the hospital. There was a tumor in the pelvis, pushing on this thing. And it was a non-Hodgkin tumor. Finally, she did not do any treatment. So the whole question of hospitalization versus what the patient wants versus what this thing. Is telemedicine an alternative? But will it help? I don't know. These statements are very important. If you don't think, you will not make it. If you listen carefully, you will think. So sometimes you need to use clinical inertia as a safeguard. So let me conclude. Whom do you put first? Institution or the patients? Self-protection versus and defensive medicine versus caring of people. I just picked up a few random issues. Don't give up the art of medicine. Make a working diagnosis. Teach our junior doctors, our students to make a working diagnosis. Make relevant investigations. Ask the right questions. Teach people to ask the right questions. Treat what you treat, but be evidence-based. And when you come to chronic patients, focus. Think. Avoid hospitalization. Shift care to home possible, but use telemedicine optimally. But always consider the direct and indirect costs. Now, why this is important? Because we are in a medical college and we want to practice excellence. I believe excellence is relevance. I was taught this by a senior mentor, that excellence is not doing the best protocol. Excellence is relevance. What is relevant? Relevant for whom? Relevant for us as a practitioner, as an institution, or relevance for the person who comes to us. It is when you think in that way, we can actually pick up one starfish and throw it back. We may not be able to change the world. Maybe one person can be helped. Thank you.
Thank you, sir. Is there any questions? Would you like to have ask, sir?
Morning, sir. I think thank you for that talk. It was it was extremely relevant in this day and age. I have two questions slash points. One is I'm a community physician with interest in palliative care. Do you think that we might actually have a bigger, when we talk about palliative care in general, we always think about cancer, but actually there might be a bigger role for it in heart failure, in kidney disease, CKD, CLD, all of these chronic conditions. And transplantation and those options are not always feasible. So in our country, do you think that there might be a bigger role for palliative care in NCDs? The second thing was regarding screening. Uh, we used to have this policy, this criteria that we teach students where, when you say that if you can't do anything about it, don't bother screening for it, right? And here you said don't chase the incidentalomas. And I think with AI coming in, everyone is very trigger happy to find out the most minutest incidentaloma and jump on it. So do you think that is, another oncoming problem that we might face in the near future?
Yeah, for the first question, I think palliation should become part of our clinical practice in all specialities and not just leave it to cancer alone. NCDs will be is the major thing today. So when you look at home care and palliation, I think it has to be both in the hospital and community based. I think it should not be just cancer based. My thing is that it should be all chronic illnesses, all NCDs which need palliation. So there is no question about it. That's very clear. Yeah, definitely yes. I think we will end up having lots more incidentalomas and diagnoses pushed at us because of technology and AI. That is where critical thinking and discernment has to be taught in medicine. If it is not taught, we'll end up being automatons driven by technology. I agree.
So Dr. Mathew Santhosh, I think you are a student of former student of Kottayam Medical College.
I am from Kottayam Medical College.
I think your classmate is sitting here. Dr. Vijayamma.
Oh, Vijayamma. Okay. I didn't see this.
Yes, I was the principal there for 3.5 years and retired as Director of Medical Education. All the points you have pointed are relevant to this era of medical students, medical practice. See, we are practicing medicine for more than 30 or 40 years. The teachers, we have the teachers that have, they studied us, the great teachers, KVK, Mathew sir, everything from Trivandrum and also from Kottayam, teach how to clinically evaluate a patient. I am working in the department of imaging, that is radiology. So don't treat images, don't treat the patients. Two issues ഞാൻ പറഞ്ഞുതരാം. രണ്ട് എക്സാമ്പിൾസ്. ഒന്ന്, പ്രശാന്തിനൊക്കെ അറിയാം, we were telling everything, ഇതെല്ലാം ഞങ്ങൾ എല്ലാ സ്റ്റുഡൻസിനോടും പറയും, you look the patient, see how he is walking into you, how she smiles at you, everything will reveal you the diagnosis before the patients take history. That was the practice we were doing. But today, in this year, we are treating the images. As far as myself is concerned, so many incident traumas in each and every investigation. For example, liver hemangioma. We will see, frequently we will see, patient comes just for the evaluation of hemangioma alone, every month, every year. Then regarding the recent BIRAS classification of the breast malignancies. So palpation, we are sure that it is a fibroadenoma. What will you do? We will send the patient after given an assurance. Then you send the patient for evaluation of breast ultrasonography. So what we will do? We will classify BIRAS 1, 2, 3. 3. Patient will be ഭയങ്കര പേടിയ പേഷ്യൻസ് ഉണ്ട്. പിന്നെ അവർ ഉറങ്ങുമെന്ന് എനിക്ക് തോന്നുന്നില്ല. Next, after review, after 6 months. 6 months, she will be with this mass in the breast, fearing that it may be cancer. What will be her routine daily activities? That will affect her activities. So one thing is, don't treat images. Images are images. The best thing is, the real thing is in front of us, that is the patient. Patient will give the diagnosis. He will take the proper history. Patient will give the diagnosis. So that we have to practice. So very relevant. You want 2 examples. My husband is a cardiologist. He was practicing in Government Medical College Ernakulam. A patient, old lady, came. സാറേ ഞാനൊരു 3-4 ഡോക്ടർമാരെ കാണാൻ പോയി സാറേ, എനിക്ക് ഡോക്ടർമാരെല്ലാം ആൻജിയോഗ്രാം പറയുന്നു, എന്നെ കൊണ്ട് പറ്റില്ല സാറേ, എനിക്ക് വയസ്സില്ല സാർ, എങ്ങനെയാണ് എന്നെ മരുന്ന് കൊടുത്തൊന്ന് ചികിത്സിച്ചതായോ? പിന്നെ നോക്കുമ്പോൾ എന്താ പറയാ, പേഷ്യൻ്റ് ഈസ് ഹാവിങ് ഹീമോഗ്ലോബിൻ 5 milligram. സിമ്പിൾ. ഇതുവരെ ഇത്രയും പേഷ്യൻസ് എടുത്തപ്പോൾ nobody tested his hemoglobin. Patient is referred for angiography, coronary angiography. Recently I had an experience in my ultrasonography room from casualty. Patient came. Patient is in bed. He cannot walk, and an emergency ultrasonography was requested. I look into the request. The diagnosis of renal calculus. Patient won't be that much sick when there is a 4 mm catheter sitting in the middle calyx of left kidney. Patient won't be this much sick. I take the history. Patient പറഞ്ഞറിയാമോ, ഡോക്ടറെ കഴിഞ്ഞ ദിവസം എൻ്റെ അപ്പൻ അസുഖമായിട്ട് കിടക്കായിരുന്നു, അദ്ദേഹത്തിനെ ഞാൻ പിടിച്ച് പൊക്കിയ സമയത്ത് ഒരു ഭയങ്കര കാച്ചിങ് പെയിൻ വന്നു. That was radiating towards the back of my leg. What was the diagnosis? What will be the diagnosis? You can be a clear-cut diagnosis of acute disc bulge. Everybody knows. But the resident, our own student, sitting in the casualty, referred the patient to casualty and to the radiologist and emergency ultrasonography. The request was calculus. I called her because she is our student. Called her, asked the patient to take the history. She took the history. She gave the diagnosis of disc bulge in front of me. So the thing is, the point ഞാൻ പറയുന്നത്, we are all medical teachers. We should teach our students the ethical practice so that we can treat the patient as a whole, looking at the background, clinical background, his family background, his affordability, and continuation of medication. That should be our message from this talk. Thank you very much for highlighting the very important and very relevant point. Thank you.
Nothing to say. Seeing him after 30 years, I think. One of you get together, I saw him, but his face and all, actually I'm remembering the first year faces and all, the beautiful hair and all. Actually, and also, so thank you, Santhosh.
Santhosh, what you said, all was relevant. I was also same boat-ലാണ്. പക്ഷെ ഞാൻ ഫിസിയോളജിയിൽ ഇരിക്കുമ്പോൾ, പക്ഷെ എന്നാലും ഞങ്ങൾ ഇപ്പോഴത്തെ ഡിജിറ്റൽ കുട്ടികൾ ഇവിടെ വന്നിട്ടൊന്നും എനിക്ക് പറ്റിയിട്ടില്ല. പഴയ കാലത്ത് കുഞ്ഞുങ്ങളോട് ഇപ്പോൾ ഒരു ക്രെറ്റിനിസവും തൈറോയ്ഡ് ഹോർമോൺ ഡെഫിഷ്യൻസിയാണോ പിറ്റ്യൂട്ടറി ആണെങ്കിൽ നമ്മൾക്കൊരു ചെറിയ ടെസ്റ്റ് ചെയ്താൽ മതി, അപ്പം മെൻ്റൽ റിട്ടാർഡേഷൻ ബിഫോർ 3 years യു ക്യാൻ സൈ. അതുപോലെ തന്നെ ഞങ്ങൾ പഠിച്ച ശ്രമല, ഞാൻ ട്രിവാൻഡ്രത്ത് പഠിച്ച Mathew sir, KVK old. Actually, എൻ്റെ മോന് വൈറൽ മെനിഞ്ചൈറ്റിസ് എൻകഫലൈറ്റിസ് 11th, 10th, 12th വന്നു. അപ്പോൾ സർവസാറിനെ കാണിച്ചു. രണ്ടാമത്തെ പ്രാവശ്യം ഡയഗ്നോസിസ് ഒന്നും ചെയ്തില്ല. അപ്പം ഞാൻ കഞ്ഞിയും കൊണ്ട് എക്കോട്ടേഴ്സ് ആയിരുന്നു. വന്നിട്ട് ഞാൻ അവിടെ തലയൊന്ന് കുനിച്ചു, എടാ വേദനയുണ്ടോ? ഉണ്ടെന്ന് പറഞ്ഞു. അപ്പോൾ പെട്ടെന്ന് എന്നെ പത്മ മാഡം പഠിച്ചു, ഒരു കൊച്ചു കുഞ്ഞ് ഇതായിട്ട് വരുമ്പോൾ യു ഷുഡ് ഡു നെക്ക് റിജിഡിറ്റി ടെസ്റ്റ് ചെയ്യണം. പെട്ടെന്ന് എൻ്റെ ഫ്രണ്ട് വത്സമ മാഡത്തിൻ്റെ മോനായിരുന്നു, ഓടി വന്നു. ആൻഡ് മൈ എൽഡർ സൺ വാസ് ഗോയിങ് ഫോർ കൗൺസിലിംഗ്. ഭയങ്കര പാടായിരുന്നു. അപ്പോൾ വൈറൽ മെനിഞ്ചൈറ്റിസ് ആയി. ഇങ്ങനെ വി ക്യാൻ മിസ് മെനി തിങ്സ്. പക്ഷേ അതുകൊണ്ടാണ് ഇപ്പോൾ റംഡ മാഡം പറഞ്ഞ്, സന്തോഷ് പറഞ്ഞ്, ഇറ്റ് ഈസ് റെലവൻറ്റ്. ഇപ്പോഴത്തെ ഡിജിറ്റൽ U3 ജനറേഷനിൽ നമുക്ക് ഇച്ചിരി പാടാണ്, കുഞ്ഞുങ്ങളത് മനസ്സിലാക്കുന്നില്ല. സോ ഐ അഡ്വൈസ് all the clinical staff to be on this way. That would be very good. അതുപോലെ ഒരു കൊച്ചു കുഞ്ഞ് കരയുമ്പോൾ നിർത്താൻ, ഞങ്ങളുടെ പത്മ മാഡം പറഞ്ഞത് പീഡിയാട്രിക്സ്, നിർത്താതെ കരയുമ്പോൾ കോളിക്ക് പെയിൻ വോമിറ്റിംഗ് ആണെങ്കിൽ ഫസ്റ്റ് ഡയഗ്നോസ് ഷുഡ് ബി ഇൻഡസെപ്ഷൻ. എൻ്റെ മോൻ 9th ക്ലാസ്, അവനെ ഒരു ബാസ്കറ്റ് ബോൾ പ്ലെയർ പൈലറ്റൊക്കെ ആക്കണം. അപ്പോഴാണ് ഒരു ചെറിയ വയറുവേദന, ആരും കണ്ടുപിടിച്ചില്ല. വൈദ്യനായൻ സാർ എല്ലാവരും കൂടെ ഇൻഡസ്ട്രിയൻ മുഴുവൻ കുരുങ്ങി ലെസർ അമ്പലത്തിൽ. ആൻഡ് ഹി വാസ് ഒരു കൊല്ലം കിടക്കേണ്ടി വന്നു. നൗ ഹി ഈസ് എ ഡോക്ടർ. പക്ഷേ ഇങ്ങനെയുള്ള കാര്യങ്ങളുണ്ട്. അപ്പോൾ ഒത്തിരി കാര്യങ്ങൾ, അതുപോലെ ഒരു ചെറിയ ഡയഗ്നോസിസ്. സന്തോഷം പറഞ്ഞതിന് ഞാൻ ഒരു വലിയ സന്തോഷം എന്താണെന്ന് വെച്ചാൽ, ലേണിംഗ് ഫ്രം മിസ്റ്റേക്സ് ഹി സെഡ്, അൺലേണിംഗ് ദ ലേൺ തിങ്സ്. ഇപ്പോൾ 70,000 ഒരു ലേഡിക്കായി. അതുപോലെ നമുക്ക് ചെറിയൊരു ഇൻവെസ്റ്റിഗേഷൻ, മൈക്രോ ആൽബുമിൻ ചെയ്താൽ, ഞാനൊരു ഡയബറ്റിക് പ്ലസ് നെഫ്രോപ്പതിയുടെ അടുത്താണ്. പക്ഷെ ഒരു മൈക്രോ ആൽബുമിൻ പണ്ട് ഞങ്ങൾ ചെയ്തില്ലായിരുന്നു. അപ്പം അത് കൂടുമ്പോൾ ഇതാവും. അപ്പം എല്ലാവർക്കും അത് കൊടുക്കുക. അതുപോലെ പീഡിയാട്രീഷ്യൻസ് നിങ്ങളൊക്കെ വരുമ്പോൾ സ്ട്രെപ്റ്റോകോക്കൽ ഇൻഫെക്ഷൻ ഒരു റീനൽ ഫംഗ്ഷൻ ടെസ്റ്റ് 400 റുപ്പീസേ ഉള്ളൂ. ഞാൻ തന്നെ ഇവിടെ ഒരു സെപ്റ്റിക് പേഷ്യൻ്റായി ഈക്കോളെ വന്ന് അറിയാതെ. അപ്പം എന്നെ എങ്ങനെയോ ദൈവം വെച്ചത് 45,000 WBCs ESR. അപ്പോൾ എനിക്ക് മനസ്സിലായി 15 days കൊണ്ട് രക്ഷപ്പെട്ടു. പക്ഷെ ഓൾ ദീസ് നമ്മുടെ ഇൻറ്റ്യൂഷൻ പവറും ദൈവത്തിൻ്റെ പവറും എല്ലാ ഡോക്ടേഴ്സിനും ഈ സ്റ്റുഡൻസ് ഇവിടെ നിന്ന് കുറച്ച് പേരേ ഉള്ളൂ. ഈ യുഗത്തിലെ കുഞ്ഞുങ്ങൾ ഇത് മനസ്സിലാക്കട്ടെ. BP ഒക്കെ എഴുതി അങ്ങ് പോകും. ഒരു എക്സാമ്പിൾ പറയാം. റെക്സാർ ഉണ്ടായിരുന്നു പീഡിയാട്രിക് സർജറി, കോലഞ്ചേരി പ്രിൻസിപ്പൽ അന്നമ്മ മാഡം. അപ്പോൾ എൻ്റെ ഡിപ്പാർട്ട്മെൻറ്റ് അന്നമ്മ മാഡം പറഞ്ഞു ബോംബെ ഇത്ര കെട്ട് സാധനങ്ങൾ ഫയൽസ് CT സ്കാൻ അതെല്ലാം കൊണ്ട് ഒരു കൊച്ചു കുഞ്ഞുമായിട്ട് തൃശ്ശൂരിൽ വന്നു. അന്ന് സാറ് തൃശ്ശൂരാണ്. He did a simple peripheral smear and the child is diagnosed leukemia. കുറേ വർഷങ്ങൾ ഇൻവെസ്റ്റിഗേഷൻസുമായിട്ട് നടന്നു. So that is a way. വളരെ വളരെ താങ്ക്സ്.
Yeah, I think Siddharth Mukherjee says a strong intuition is more powerful than a weak test. So I take it as a good thing. Thank you.
Thank you, sir, once again for enlightening us on what should be a basic primary lesson. Thank you all for